All right. Well, thank you everyone for coming. We know on behalf of Diffuse Synthase and the AOTK that you have many of options during the lunch hour to attend to and do things, even time for your personal selves. And so we thank you and we're honored that you've come to see actually some pretty innovative new technology, especially with regard to cephalomedullary nails. I just want to say a word about innovation because we tend to get caught up on the glamour of innovation and all these new things. You know, we don't innovate to give engineers jobs or to keep them entertained. We don't innovate to give doctors and surgeons new toys. We don't innovate to just, sell more products. But this is why we innovate. PowerPoint, please. We innovate for our patients. And I feel very strongly about that. We keep that perspective. Patients like this 82-year-old who tripped in her garden, mitral valve disease, she's on Coumadin, she ambulates independently at home but otherwise uses a wheelchair. Horrible fracture. A 54-year-old, healthy, active female fell off her horse. This patient, 95-year-old, he fell when transferring to a chair. He lives in hospice. He has metastatic lung cancer. He's on hormone 2 and a minimal ambulator. And finally, this patient, 85-year-old, fell. He has congestive heart failure. He's had a coronary artery bypass. He's on Plavix, but he ambulates independently, but not with this anymore. So these are the challenges that we have, and this is why we innovate and try and make new products. Now, there are currently very good products on the market. There's no question. The TFN, the PFNA, Gamma Nail, you can just go down the list. Everyone has a good product. We're all using them. We all have pretty good success. But there still really remains several common clinical challenges that our current implants don't handle as well as they could. And so in collaboration with Diffuse Synthase and the AOTK INEG, group of surgeons have gotten together with engineers and they've come up with this list of current clinical challenges that really need to be addressed to take us to a next step forward where we can provide our patients with better treatment. And these include radius of curvature mismatch and poor anatomic fit. And especially if you need to use a long nail, we've had problems with anterior impingement and cutout. We also have problems with placing our implants in the safe position and having cut through or cut out. Implant breakage continues to be a problem as we treat more and more complicated fractures, and our nails are just not quite able to stand up to the challenge of the prolonged healing time. Leg shortening, lateral protrusion of our implants with collapse is a big problem. It creates pain and disability for our patients. And then we have issues with instrumentation, how to apply these implants. It certainly can be more efficient. And then limited options, not having enough options at our disposal to make changes in surgery as well as provide our patients with the type of implant they might need. So these are the common clinical challenges that need to be addressed. In addition, we have to keep in mind our goals of surgery. We want to be as minimally invasive as possible. We want to have a one-shot surgery. These patients are not, you saw that list, these are not healthy people, many of them. And they cannot tolerate revisions and having to go back and deal with non-unions and failures. We need one-shot surgeries for them. We need to make them immediately weight-bearing. We need an implant and fracture surgery that allows our patients to get up and move immediately. They cannot be off their feet for very long or they get deconditioned. We need to adapt our implants and use precise techniques and tools that we're going to show here today that hopefully help make our treatment better for our patients. So the solution, all of those clinical problems, every single one of those have been addressed with the new TFNA. And that's what I want to do here today is show you how each of those problems has been addressed by this new nailing system. And so, like I said, this was a work over many years between Diffuse Synthase and the AOTK INEG. This is just an example of us working together in the labs. Lots of research, clinical tests, placements in cadavers. It's been thoroughly vetted out to give you the final product as we're going to show and has been released. So let's start out with the first challenge, which is radius of curvature mismatch. You can see here a couple of disasters, right? These long nails that are fairly relatively straight have large radius of curvatures averaging around 1,200 millimeters or 12 meters. 1.2 meters. But what's interesting is that when the engineers and the researchers have studied more in depth and in more detail using three-dimensional computer modeling, they took 27 Caucasians and 13 Japanese patients, and they modeled their femurs, and they did a very extensive study of their femoral canals. They actually found the radius of curvature in Caucasians is around 1 meter, and in the Asian population is more like 800 millimeters. So much less, and that's why we're running into issues of impingement. And so the new design has a radius of curvature of 1 meter. It's a nice compromise between those two, and you can see a difference in those x-rays right there. The nail fit of an older design and the more contemporary design with a better radius of curvature. And just to show you kind of what the real nail looks like, this is it here. And if you could show that this is just the nail here, and you can get an appreciation for that much increased radius of curvature bend in the nail. So that's a really important feature, especially as we're treating more extensive fractures, periprosthetic total knee fractures, or needing to go long with our nails. We need to do that safely. And this new radius of curvature has made a huge difference in my practice. So let's go to the PowerPoint again. This is just a clinical example, again, showing that lateral view of the distal femur and how that nail fits very nicely in the canal. The next challenge that I want to address is poor anatomic fit. This is really important, and I don't know, yesterday in the Master's Lower Extremity course, we showed a lot of cases and disasters that are related to this problem. And the issue is with our large nails, large proximal diameter nails that are big and round, we create secondary displacements when the nails are inserted. And many of these fractures, as you can see here, are comminuted at the top, and their fracture lines enter right at the point where the nail is to be placed into the bone. And what happens is this big, large implant goes in, and as it slides in, it pushes and moves the fragments away so it can find a place to go. And so you can see here how we create secondary deformities. We actually shift the bone, the proximal segment away from the shaft. We create gaps and instability and problems. We create malalignments. A lot of times it's so tempting to go in with a bone hook or a collinear clamp, grab that lower calcar area and squeeze and pull it in. But what does that do? That just creates another problem. That creates varus. So we want to try to avoid these problems. We need a better design. This is just another example about how this lateral displacement of the shaft occurs. You can see an attempt at using a curette to curette the bone out more medially. So there's several things we can do to help avoid that. One is try to have a more medial entry of our nail. We can try and preliminary reduce and then hold that fracture with some type of provisional implants or fixation. We can help through nail design. We can flatten the nail laterally, and we can make a smaller nail diameter. So I bet you can guess what I'm going to show you, right? So this is exactly what the new nail has. This is called the lateral relief cut, and they now also have a new proximal diameter. It went from close to 17 millimeters now to 15.6, and they've created this really interesting flattening of the lateral side of the nail called the lateral relief cut. This is a little video here to demonstrate that. I want you to just kind of take a second and watch this. This will kind of give you a nice example or a demonstration of what I'm talking about. So the nail is now narrower in diameter proximally, so it doesn't need as much space to fit in. It won't move the fragments around as much. And then on the lateral side, it's flattened. So as it enters the bone, you're going to see here, it really decreases its impingement on the lateral cortex. So in this region right in here that gets shaded, that's where the nail begins to impinge in a more traditional design and then creates secondary deformity. The nail has other features. They've through this computer modeling and these studies of cadavers, the radius of curvature bend is now starting more distally, and the lateral bend is more proximal. So I don't know if we can just show that real quick in the, if we can zoom down on this. So there's the lateral bend right there, and it occurs much more proximally than it did in the TFN and other designs. And then I don't know if you guys can actually see, but see that flat surface right there? That's the lateral relief cut. And that allows that nail to insert into there with much less involvement of the nail in actually affecting fracture reduction. It actually slips in and fits very nicely. Back to the PowerPoint, please. So the next challenge that we have to deal with, that has been identified, is a suboptimal placement of the head-neck element. And this is very important. We've all heard about tip apex distance. We've all heard about getting, a head-neck element in the center position of the femoral head. We all know this stuff. This is all, if you're a practicing orthopedic surgeon, you're learning this, you've learned this in your experience, you've learned this from research, and you learn this in your courses. The tip of the implant has to be within 5 to 10 millimeters of the joint, and it has to be parallel to the femoral neck. And that's great. It all makes it sound really easy. The problem is with many of our current instrumentation for the nails that we have now, it's very difficult to see, especially on the lateral view. The implants or the insertion jigs they're too bulky, they're too difficult to see through. So the solution that we've come up with is basically a fully radiolucent insertion handle with some radiographic markers that are embedded in it and also added onto it that give the surgeon exactly the landmarks and clues and the visualization to place that head neck element in the center portion where it's supposed to be. This is the jig here. You can see a tiny bit of metal here and a very little bit of tiny metal up here, and the rest of it is completely see-through. That is huge. Let's go back to the PowerPoint real quick. I'm going to show you some examples. So on your AP view, when you're inserting here, we'd like to know exactly where that implant's going to go. And you can see here there's this radiolucent carbon fiber paddle that projects those lines on the neck. And if you place those appropriately as in the technique guide, it'll show you exactly where your head element is going to go. This is the paddle here, live. You can see. You can see the markers. And this will attach simply onto this handle, and then the X-ray images through this, and that gives those markers back on the PowerPoint, please. As you can see there. So that gives your AP alignment. And then the lateral view, this is where I think the money is right here. So this is just showing that's the jig. You can hardly see any of it because it's radiolucent. You see those two lines? Those are radiographic markers that are embedded into the insertion handle. And if those are aligned properly, as you can see here, on each side of the nail as it's inserted, the guide wire will be directly down the center of the neck and into the center of the head. And that's how you can judge. And you can see that very, very clearly like that. Of course, it takes the proper position of your C-arm image and your projection of the hip. It needs to be in a 180-degree neck shaft angle. So once you make that adjustment, then that's where these radiographic markers work. So you can see here how that would be perfectly aligned. And then this is just an intraoperative X-ray to show how that would go right down the center. Because you know that you can have confidence that that's where it's going to go. This is just real X-rays here, real time, showing on the lower X-ray on your left, shows how the jig is not properly aligned because obviously that's going out of position, and then when it's properly aligned, it goes, when the two markers are properly aligned, it goes right through the center. This is just what final product would look like, how it really is nicely seen very clearly on the imaging intraoperatively. So when you leave the OR, you know that your head element is in the exact position that you want it. So the next challenge is fixation in poor bone. And again, this has a lot to do with what we just talked about. First of all, getting the head neck element in the proper place, but then how do we deal, once we have it in the right place, how do we prevent it from cutting out through much of this very poor osteoporotic bone that we deal with on a daily basis? So we've come up with two options for head neck elements. And these, again, give surgeons tremendous ability to choose and have options in surgery. If we can go to overhead view, I just want to show you the two options that are available to be used with this system. One is a traditional lag screw design, as you can see here. So if you're comfortable with that, if you've been using this kind of design for years, it's available to you to use. And there's also a blade element, as you can see here. This is, we'll talk about this in a second. And if you've already noticed, you can also see, barely, but you can see it, there are little holes in it, right? So we'll talk about that also. Back to the PowerPoint, please. So what's nice about the blade is the blade is a device that does not remove bone. So when you place the lag screw, right, you ream for it, generally. So that removes bone. That's a completely the opposite of what we want to do when there's very limited bone. We want to keep as much of it there as possible. So what's nice about the blade is that as it impacts, you don't pre-ream for it. You put it in like a blade plate or any other blade. It's impacted, and the bone compacts around the blade, which provides significant stability to the construct. You can see how much bone is displaced by the blade itself compared to what a lag screw would do. So this is in parts. It's working, the implant's working with the current existing bone to provide stability. So that's a really nice feature of the blade. In addition, to provide even more secure fixation, there's the ability to augment the implant with polymethyl methacrylate. And so that's what those little holes are for. Now, this is not available in every country. I know it's not available in Japan or in North America, but everywhere else I believe that this will be released is generally it's going to be available. So augmentation is going to be very, very helpful, and I'm looking forward to its approval in the US. But this is kind of what it would look like real time, if we can go overhead. So what happens is through a very specialized insertion device, which is right here. This is cannulated. This goes up through the head neck element. So we see here, this will go in through and then you actually turn this handle. This is all preloaded with material, and then it squirts out those holes, as you can see on this model, and it creates a very large surface area of contact to prevent cutout and cut through. So if we can go back to the PowerPoint, please. These are just some details on it. It's polymethyl methacrylate cement, and this actually has been shown to give 100% improvement in anchorage in the bone compared to no augmentation. So that's pretty dramatic. And there are no adverse outcomes that we know about so far. There's been no reported cutouts to our knowledge once augmentation's been used. So this is just an example of what it would look like on an x-ray. This is a 93-year-old patient with severe osteoporosis, and you can see how that augmentation fills the head, and again, it's a collaboration of the bone, the cement, and the implant working together to provide stability, as opposed to just hoping and relying on a lag screw and no bone to hold that fixation. So really a tremendous advantage, a nice advance. It's just another example again. The next challenge is nail breakage. And you can imagine as these fractures take longer to heal, we're relying more and more of our implants to hold up until the healing process is complete. So in order to go, you can imagine if the new nail design has gone smaller diameter, it's not as strong as it used to be, right? So how do engineers deal with that? We have a smaller implant, smaller diameter, but we need a nail that's stronger. So that's where engineering innovation is pretty amazing. And that's why these guys are smart. So what they've come up with is a whole new alloy. It's a titanium moly, call it Ti-moly alloy, which is much stronger than the traditional titanium alloy that we used. And they designed this really interesting feature on the main lag head element hole through the nail. And it's, as you can see it here, I don't know if you can notice, it's irregular, right? That's a good shot right there. There's a little bump in the edge of it. Doesn't look like much, kind of looks like it, I don't know, just this little bump. And they actually call it the bump cut. If you can go back to the PowerPoint, please. And some really smart engineers have figured out that by making this little bump on the edge of the hole, it provides a tremendous strength to it, and which is really fascinating to me. So it actually has been shown to have 23% higher fatigue limit than a gamma 3 nail just by adding this special feature to the hole. So that's a innovative technology that's very subtle, but that's what a lot of these things are. So the next challenge is preventing significant leg shortening and protrusion of the head element and the problems that causes. So what's nice about the new locking mechanism, it gives the surgeon a lot of options. So there's two real options. You can have rotational locking, and you can add static locking if you want, or dynamic locking. So this is this locking mechanism is preloaded into the nail. You don't have to add it in later, and it works very nicely. I'm going to show you a video that demonstrates this. So as you can see here, a screwdriver is inserted through the top of the nail and through the handle, and as this locking device is tightened down, you can see that side piece slides along the nail, and that provides the rotational stability, but still allows the head element to collapse or to be dynamic. Of course, if you have any reason to want to make it static, you can tighten it down. There's a special torque limiting screwdriver, and it will lock that locking device against the head neck element and keep it from sliding. So rotational stability, sliding stability if you want it. If you don't want it, don't do it. It's your choice. You're the surgeon. You can make those decisions. All right, next PowerPoint. So then the other thing is, this is just kind of, it's a nice feature. It's kind of subtle again, but if you look at this PowerPoint slide, you'll notice that the lateral edge of the head neck element is tapered. It's actually smooth and tapered to the shape of the femur. If you look at compared to a traditional head neck element, it's rounded and it protrudes. So when this is properly inserted, it will lie flush to the bone and not create soft tissue irritation. Yeah, so see, that's how that's tapered. So it's, again, another subtlety that you wouldn't just pick up, but it's been thoroughly thought out as to how you can avoid soft tissue irritation on our patients. So you can see here, this is a intraoperative or a postoperative x-ray. You can see how that is very smooth and flush to the bone there when it's properly inserted. So there's nothing sticking really out of the bone to irritate the soft tissues. So the next challenge doesn't have to do with the implant, but it has to do with how we insert the implants and how we manage our back table and how everything is assembled. So it's an interesting kind of new technology called the quick click self-retaining technology. And so watch this. This is really a nice new feature. It's going to really help us. This is a self-retaining, flexible, kind of springy connections. I don't know how many times your back table has dropped one of those bolts, but the fits very nicely. The implants have a snug fit to them, but they're flexible. They're easily removed. And what's nice is that you won't drop things. Your nurses on the back table, implants won't come apart as they're being passed from the back table to the surgeon. As this fits, let's go to overhead. So there's no bolt in here, right? This is like a magic show now. There's no bolt in here anymore, but this is not coming off. So I don't even need the bolt. Well, I do, but the smaller one stays on very, very nicely. I mean, it's not going to fall on the ground as the nurse hands it over to the surgeon. Works the same on the long nail, but obviously as the long nail gets longer, it's not quite as stable, but it still won't just fall off in surgery. So that's a nice feature. Or PowerPoint, please. So in terms of instrumentation and innovations in instrumentation, this is also one of my favorite things, probably because I have trouble getting the right entry point, usually, as we all do. But there's a multi-hole wire guide and protection sleeve that's I'm going to show you in just a second. But if you prefer an awl, then an awl is available to you as well. So again, it gives the surgeon options, and that's what one of the really great features of this new platform is. But this is a really nice device, this multi-hole wire guide. It's, as you can see here, it has 3 holes in it, and you can get up to 10 millimeters of adjustment. So if you get your wire in, your starting wire in, you're just not quite happy with it, you wish it was over 4 millimeters or 6 or even 10 in any direction, then you can simply now place another wire and get any of those dimensions changed without having to completely remove your wire and try and just keep going again. So this is really cool. There's a little video on it here. There's nothing more frustrating than trying to, making multiple attempts at trying to get the right wire. You get one that's close, and so kind of keep the temptation from saying, oh, it's not great, that's good enough. This will help you make it perfect, and that's important in these cases. So it's just showing how you can make adjustment. Another wire can go in without having to remove the other one, and you can improve the position very simply. So that's just it just wanted to go a little more posterior, and that's what they did. They moved it 4 millimeters posterior. So there are several opening reamer options. There's a flexible reamer and also a solid reamer. And then there's one more new advance that just came out, and we'll show you that in just a couple slides. But again, there's options for you, whatever you prefer and whatever you find more useful in your hands and for the clinical situation. This is also another very important device. This is called the reaming protection tube. I don't know how many of you have had the unfortunate experience of getting a good entry point. Maybe you're dealing with a very heavy, large patient with a large soft tissue envelope, and you're just really struggling to keep that there, and you're feeling a lot of soft tissue pressure against your hand. And all of a sudden, you're starting now to ream your canal, and you're just glad to even get a reamer in there. And next thing you know, you insert your nail, and the nail is way lateral than where you wanted it to be. So what has happened, right? It's just that soft tissue tension or pressure against your hand has caused your reamer to, every time you enter the entry hole, just reams out a little bit more of the lateral cortex, and then a little bit more, and a little bit more. Next thing you know, you're in not a good situation. This tube then can be inserted into the hole that you just reamed with your opening reamer. And as you can see, go quick to the PowerPoint. You can see here it inserts into the opening hole. And now each time you pass your reamer, it goes through the sleeve instead of eroding away the more lateral cortex. So I really think this is really, really a nice feature of this, because that is a disaster if you remove more lateral cortex. You lose a lot of fixation. And so this is a device to help keep us out of trouble. Thank you, engineers, for that, because that's a big mistake and a big problem. So nice feature to prevent that. Okay, the PowerPoint again. And then there's some other features to help us maintain reduction. So I don't know if you're also doing cases and you only have 2 hands and you're trying to like hold things and get this nail in and not lose your reduction. You're just praying that by the end of the case it still looks good. So there's features to help with that too. And this is nice. This is a little sleeve that will come right off the jig, or the handle, insertion handle. And you can put a long wire through this, as you can see on the PowerPoint, as you used to see on the PowerPoint, but this is what it looks live. So you can see how this wire will go in. It will not impede or it does not interfere with the placement of the head element, but it will help hold your proximal segment stable, or at least more stable than just letting it kind of freely float there. So this is the sleeve. This is what it looks like here. And just, it's removable. You don't have to have it there, so it won't clutter and look at a lot of things, interfere with stuff that you're doing. But if you want to have that extra hold, you can use this to help guide it in a position that won't interfere with your placement of the head element. And then this also has features, the blade or the lag screw entry device, or the thing that impacts the blade up into it, as you can see there. It has the ability to also compress. So once your device is in place, this is kind of the main hardware here. So this nut spins, and once this is all down in place, all the technique will discuss all of these things. But once you have your head element seated, you can actually just dial in a little compression to help close down those gaps that you may not want to see there. I like to leave the OR with my fracture obviously reduced, and I like the patient to leave the OR with as much stability in their fracture as possible. It's very tempting to see gaps and stuff and just say, well, when they put weight on it, that'll just collapse on its own. But that's an unstable situation. Instability causes pain, and it causes the potential for loss of failure of reduction. So if I can, I try and reduce those gaps. This is a nice way to do that, in addition to obviously letting off some traction. There's one also for the lag screw. So this is actually for the blade, and then there's one that we can use with the lag screw as well. PowerPoint, please. We've just basically are going to release this device called a hollow reamer. And let's go back, think about, we were talking about secondary displacement from our implant, right? So that's a big problem. And that may actually start with our starting reamer. If we're entering very near the fracture edge, or the edge of the fracture as it's coming out the trochanter, and we put in a big reamer, solid reamer, or even this flexible reamer head, it's going to go where the least resistance is, right? It's going to go right through the fracture, and it's going to, It's going to push, instead of reaming, it's just going to push the fragments away, and then you take the reamer out, and you haven't really done anything. So you insert the nail and just pushes the fragments away. It's going to look something like this. You can see here, this would be just a drawing of what you put in a solid opening reamer or a big awl. It just spreads the parts away, right? So we don't want to do that. We actually want to create a space for our nail that's not going to displace the fracture. So that's what the hollow reamer is supposed to accomplish. You can see here it cores out a hollow piece of bone or carves out a channel that doesn't then displace. It actually reams the bone and takes a part out. Let's go to the overhead for a sec. This really is like breaking news. I just learned this today, that this is now going to be released, because we've been dealing with this for a while, wanting this to come out, but it's now available. So let's see, you can see here, it's a hollow reamer with teeth, and it'll go in, carve out a channel, and then your nail will go into the channel as opposed to just displace the bone. So we now have 3 ways to open a proximal femur. Again, this whole theme of giving surgeons control of what they're doing in the OR, not being told this is the only thing you can open the femur with. So the next thing is options, and you've already heard me talk about multiple options with instrumentation, multiple options with alignment, guides, and all these things, but there's also lots of options for nails. So you can see here, this is just showing a little bit of the portfolio. The nails are going to come in a short and kind of a medium length, I guess you'd call it, and then a long length. And you can see here all the different size nails that are available. They also come in 3 different CCD angles, 125, 130, 135, to match the anatomy. We want that head element to be as parallel to the center of the neck as possible. And we have large nails too, so the long nails, diameters of 9, 10, 11, 12, and up to 14, and they come in all kinds of lengths. So, and again, a radius of curvature of 1 meter. So lots of options. And again, we talked a little bit about options and head element, so you have a choice between lag screw and blade based on your preference, what the patient needs. And then the final thing is distal cross-locking. So in the obviously in the shorter nails, it's just a single cross-lock distally, but in the long nail, there's 3 options, and one of them has a 10 degree, it's a multi-planar locking distally to get better fixation, and also targeted toward the best bone in the distal femur. So that's why there's that angulation there. So dynamic slot, 2 static slots, and then one of the slots is angled at 10 degrees off axis to target some better bone up in the cortex. So PowerPoint, please. A couple of case examples. This is actually the very first TFNA that was clinically inserted. This is sorry if the imaging's not super good, but you can see a very heavy patient, very challenging A2 fracture on the right side there, and we chose to insert a long nail. But I just want to point out that lateral view distally, right? This is very osteoporotic bone, and if there was anterior impingement of that nail, it'd be very risky for a periprosthetic fracture or a problem. But that thing it's really nicely in the center of the canal, so it's a huge feature. A more different case, more of an A3 type case. Transtrochanteric, nicely handled, good placement of the implants. We chose static locking with 2 screws. And again, lateral is the key, right? That lateral x-ray, that view there is what you want to see, that nail is safe. So this new nail has given me a ton more confidence. I'm not as nervous putting that thing down anymore. Getting a little more complex, right? So just examples. Everyone see these x-rays all the time, and now a very extensive comminuted into the subtroch region fracture. And again, this one is fairly close to the anterior cortex. Based on our other imaging that we'd had from the other cases, we know that that nail is properly, has an appropriate radius of curvature. And again, even with that, look how much it's impinging on the end. If that was any other nail design, that would have been through the cortex. So that's a very, very important point of this. So in summary, I just want to go through the common clinical challenges are radius of curvature mismatch, poor anatomic fit, suboptimal placement of our implants, cut out and cut through, nail fatigue, leg shortening and lateral protrusion of the head element, instrumentation and implant removal, and limited options for our surgeons. These are common clinical challenges, but we have uncommon solutions with this one nail. We've improved the radius of curvature, we've improved the nail shape. Radiolucent handles with targeting aids lets us get the head element right. It's a helical blade option with or without augmentation, improves our fixation and osteoporotic bone. Stronger nail, improved materials, some design features that provide strength. Option for static or dynamic locking of our head element, as well as nice allowing slide and rotational control. Quick technology allows ease of use on the back table, safe passage of instruments between the back table and the surgeon without dropping and losing things. Surgeon has multiple options for nail length, nail diameter, head element choice, blade or screws. So thank you on behalf again of the INEG and DePuy Synthes for coming and listening. If I could answer any questions, I'd be happy to take them now or afterwards if you have anything, or you want to come up and look at something, I can show you something in more detail or more specifically.